Welcome to Chapter 11. Chapter 11 is about understanding the healthcare structure in the United States, if indeed we have one. The book actually questions whether we have what you could really call a structure, because a structure means that each part is considering the other parts that are around it, and generally there's an overall theme, and there's planning and coordination that happens, and sometimes that isn't present, or at least it isn't visibly obvious within the healthcare system. However, a lot of people are working for it, and a lot of people use it, and so with that in mind, we'll go ahead and get started with this chapter. The book starts by talking about a spectrum of care, and a spectrum, kind of like there's a light spectrum. You've got certain wavelengths of light, and then over here you have different, and then along the scale there's things in between. And so looking at the first one is population-based, which means it's going to be aimed at every American. And this is the public health practice. And this is aimed at preventing disease, it's aimed at health promotion, education, and government action that is intended to increase the overall health of Americans. There is also medical practice, so moving one to the left, for instance, which is the services of doctors and their traditional staff. And as a part of this, there's primary care, and primary care is generally people's first contact with the medical establishment. They're going to do things like checkups and prevention, such as vaccines and education related to, say, nutrition or smoking cessations. And then there's secondary medical care. And so let's say the primary doctor says, you know what, I really want you to go see somebody about that spot on your arm, because the primary doctor knows a little bit about a lot of different things, but let's say a dermatologist is going to know a lot about just a few different things, right? And so the specialist has their specific focus, and they are usually get referrals from the primary doctor. In fact, some insurance companies will say that we're not paying for a specialist unless you receive a referral from your primary doctor. Right? And then there's a tertiary care, which is very, very specialized and may have technology as a main part of it. And this could be things related to, say, cancer, or it could be dialysis. So that's the second part of the spectrum. The third part is the long-term practice, and this is given to people after they receive surgery, maybe in a rehabilitation unit or in a nursing home. It also doesn't have to just be people who are recovering from operations. It could be that people, maybe they are very sick, and the expectation is they are not going to get better, but they need a facility where people can care for them. And so people with chronic illnesses, and oftentimes this is people in their elderly years, right? And then the fourth part of the spectrum is end-of-life practice. And this is the practice that's given shortly before death. I oftentimes think of hospice, although there's a little bit more than just hospice. And this is aimed at it's not healing focused, or it's not like you're not trying to make the person better. You're trying to focus on comfort, trying to make sure they're not in pain, spirituality, legal issues, bringing that family together, making sure that any last wishes or desires of that person, that those are taken into consideration. All right, let's look at the types of providers that exist within our healthcare system. So there's actually quite a number of healthcare providers. Our book estimates that about 1 out of every 10 workers in the United States economy is a part of this. And there's been growth, especially in rural and inner city areas, as I believe those have not traditionally had as many healthcare providers in them. So many of them work in hospitals, but lots of people also work in outpatient facilities. So the type of workers that are there. Well, there are individual providers, and they have education and authority to treat any issue. Well, there are 6 types of workers that we're going to talk about that are within this spectrum. There are the individual practitioners, and they have the education and authority to treat any issue. When we're looking at our doctors, there are 2 types of doctors in the United States. There's allopathic and there's osteopathic. Allopathic means that there's a specific remedy for a specific illness. Right? So if somebody has a headache, then they're going to be given an aspirin. I don't know if the doctor is needed for all that, but the aspirin is a specific thing, and it's just meant for the headache to be taken care of, right? Osteopathic is similar to allopathic. By the way, allopathic doctors are MDs, medical doctors. And osteopathic are very similar to allopathic doctors, but there's more of a focus on the structure of the body, so a little bit more on the connectedness to it, and more on little more on the function of the body. So there's a little bit more connectedness. And so the difference between allopathic and osteopathic is that allopathic is going to have the mindset of the individual organs or the individual parts of the body and kind of thinking about them in isolation. Whereas the osteopathic is going to be thinking more about the whole body and how it interacts with itself to form whatever health outcomes are present. There's also a little bit more focus on physical manipulation for osteopathic rather. So, but both of them have 4 years of medical school and 3 to 7 years of medical specialty in residence, and they have exams, and this is all after the bachelor's degree, by the way. So both of them just are in school for a really long time, and then working under other people for still quite a number of years. So, all right. So you might be thinking, well, if these people are allopathic and osteopathic, what would it look like to not be that person? So there are non-allopathic practitioners, but these are typically considered alternative medicine in the United States. These are your non-traditional doctors. They may be coming from more Eastern ways of practicing medicine, like China or India. Chiropractors, herbalists, homeopathic practitioners. It is difficult to distinguish non-allopathic practitioners that are good and effective versus those that are not, at least for me. But you should know that some of them really do have science to back up the effectiveness, and so they should not be disregarded because maybe 1 or 2 of them was just sort of selling snake oil. And so there's also been an increase in non-traditional medicine as our traditional medical doctors have become extremely busy, and the cost of traditional care has grown more and more expensive. And a lot of people are feeling like it's very expensive and they're not able to spend time with us, and it may not be even effective. And so they're looking to alternative medicine practitioners or non-allopathic practitioners. So I've had a pretty good experience with these providers. So, all right, and then there's limited care providers, and these would be people that just specialize in just a one area, like a dentist. He's not going to look at your foot; he just does teeth, right? Or an optometrist, just working on the eyes, right? There are nurses, and nurses would include, RNs, registered nurses, LPNs, APNs. If you think about your nurses here and then your doctors here, then there are people that are in the middle, and they're a little bit above nurses in terms of their authority and their ability to give treatment, but they're not at a doctor's level. And those would be people like nurse practitioners and physician's assistants. The number of people in these positions has increased recently, as doctors are very expensive and require a lot of training in order to become a doctor, and yet there's an increasing need for practitioners, and so kind of that the middle people are there doing what a doctor might traditionally have done in the past. So, and then there are the allied healthcare professionals, and these complement the main practitioners. And so these would include people like x-ray technicians and operating room technicians and dental hygienists and record keepers and social workers and psychologists and all these kind of people who are helping out the main practitioners, or maybe they're behind a desk doing paperwork or just doing the things that support the doctors. And then last but not least are the public health professionals. And public health professionals, they're the ones that are going to support the delivery of healthcare services. They're not providing the services, but they might be providing the transportation to them or providing the information about the treatments that are available. These would include environmental healthcare workers and public health administrators and epidemiologists and health education people. And these are oftentimes tax dollar funded. Well, let's move on and talk about the facilities where healthcare takes place, right? And so starting with inpatient, and inpatient is where the patient will sleep at the facility, or at least has the option of sleeping at the facility, such as a hospital, right? And in 2019, there were 6,900 hospitals in the United States. And there are some that are private, and there are some that are public. And the private ones, there's some of the private ones are specialty focused, and oftentimes these specialty focused hospitals, and they're just doing one sort of working on one specific issue. They may be doctor owned, right? And then there are public ones which are taxpayer owned. The government runs these. These would include like the Veterans Hospital and Choate Mental Health in Hospital, which is a mental institution, a mental hospital, and then university hospitals that are associated with a university. And then there are non-for-profit hospitals, and those, I believe, the one in Carbondale and then I think maybe Heron, the SIH hospital system, that is non-for-profit, I believe. And there's almost 3,000 of these hospitals in the United States. If you've noticed that in the last 5 years, a lot of hospitals have actually expanded. And I think the reason that they've expanded is because they're anticipating and probably already experiencing a lot of extra need for healthcare services in inpatient facilities, especially as our population is getting older. Well, then there's also outpatient facilities. And outpatient facilities is where the person is coming there, receiving a treatment, maybe even a surgery, and that surgery may, 20 years ago might have taken place in a hospital, but now that we've got better drugs and better trainings, and people are able to get that surgery and leave the same day. So more services are being occurring in the outpatient facilities. And it could be in that one building that there's many different practitioners doing many different procedures there. All right. When someone has an emergency, they are often steered toward the emergency room at the local hospital, right? And then if somebody has an illness, let's say, or an issue that can wait a few days or a few weeks even, then they're sent to their doctor, who's generally at an outpatient facility. But there's a need, a gap between these two, and this is where urgent care sort of fills in the gap, where they're able to do some of the same things that an emergency room can do, but they don't have all the fancy equipment and training and specialists that an ER room would have. All right, well, let's look at the function of a healthcare system. Ideally, the healthcare system that we'd want would be one where there's lots of access, where people can get to the care that they need fairly efficiently, and one that considers cost containment. It's not overly expensive. And then it's quality. You obviously want quality care, right? And you can think about this as a triangle. I think our book actually uses the triangle idea. And that is good because if one of them expands, so let's say the quality expands, which sounds like a good thing, right? The issue, though, is that the other two struggle because if the cost expands, if the quality expands, then also the cost is generally going to expand, and the access may also shrink, right? Because you're putting more resources toward quality, which means you're taking away some of the resources that would allow people to have access to that. And the same thing for all the rest. If access expands, then quality and cost containment are also going to shrink. So, all right. Speaking of access, access is a real problem, especially for people who are uninsured. People who are uninsured tend to be younger and have less education. They tend to be poor. They tend to be non-white. Oftentimes, they're lost. Their job, or they've had a change of employment. And since most people's health care insurance is tied to their job, they may have lost their ability to have health insurance while they've lost their job. They're in between jobs. So they oftentimes lack primary care, which is where they're going to get their checkups and if they're pregnant, prenatal vitamins and screenings and things for that. So being poor in the United States, or being considered poor, gives you access to Medicaid, or at least for some people, they qualify for Medicaid. But if you are above the poverty line, but pretty close to it still, you may be too rich for Medicaid, but too poor for health insurance. Right? I mean, you can't buy it on your own. Maybe even your employer offers it to you, but the cost through the employer may be more than you can afford. When it comes to quality, obviously you want people who understand how to effectively treat illnesses and diseases and disorders. You want positive outcomes, and you want the treatment to work. You want people to be healthier because of the healthcare system that we have. And this is measured by it being safe, the medical treatment, and it being timely, and it being patient-centered, which means that the patient's needs and desires are taken into consideration, and it's equitable, and it's efficient, right? And we measure those things based upon accreditation and certification, how patient outcomes are doing, and then surveying patient experiences. So, the cost of healthcare in the United States is the highest in the world. We got some information in the book, but it's actually fairly old. It costs over $10,000 per person per year. That's how much the healthcare industry costs. And that's more than any other country. If you look at on a per person basis at France or Mexico or any other country, we spend the most here. And this has not been slowing down, unfortunately. And so this is a major concern for many people, as healthcare issues are the number one cause of bankruptcy in the United States. So, but how do we pay for healthcare in the United States? So consumers pay about 10%, and private insurance pays about 30%, and then government insurance pays for about 40%, and then there's other funding sources or private funds. And this is one of the reasons why I think healthcare system is overly complex, is because patients are only paying for 10% of their care. Insurance companies are paying for some, the government's paying for some, and it's kind of confusing as to how much something is going to cost. Oftentimes, patients are surprised when they receive their bill, as it seems, fairly random as to how much they were charged for various things. So, talking about these payment sources, we're going to start with the government health insurance. Medicare is the government health insurance that covers people who are over 65 or 65 and older, people with kidney failure, some of the disabled individuals. And it's a contributory program, which means people are working and they're paying into the system. and then when they turn 65, then they receive the care, right? So they've been paying in their working lives, and then when they're 65, then they get access to it, right? And there's 4 parts to it. You might have heard of Part A and Part B and Part C and D. You've probably heard of Part C the most because that's where private insurance can pay for part of it. But each part is a little bit, helps. Each part pays for a certain part of someone's care. So Part A is about hospitals, and Part B is about doctors and medical equipment, and Part C is the health insurance part, and then Part D is the prescription coverage. Right? But that's only for the elderly and a few other groups. Medicaid is for low-income Americans, and the individual states get to determine who qualifies for that care. There's about 75 million Americans who are on Medicaid currently. The majority of them are actually children. If you consider the CHIPS, which is Children's Health Care Insurance Program, then most of the people who are on Medicaid are children, right? And the federal and the state government share the cost of Medicaid. CHIPS is part of Medicaid, but it allows people who are too rich for their children to qualify for Medicaid, but still would struggle to pay for health insurance for them. Plus, you could argue that children's health care costs are going to be lower than adults and the elderly. Let's talk about health insurance and how it works. It's a little bit of a complicated system, and I have to introduce a few terms here. But you have Blue Cross Blue Shield, let's say, and they have a client, and that client's name is Jane. Now, Jane pays money each month to Blue Cross Blue Shield, right? And we're going to call that capitation. Right? And it's a monthly charge, and it's $500 whether she uses that health insurance or not, right? Now, let's say that Jane then goes to the doctor and gets a checkup, and the doctor writes up a bill for $300 and sends that to Blue Cross Blue Shield, right? Blue Cross Blue Shield then sends a reimbursement back to the doctor. However, that may not necessarily happen, because let's say it's the beginning of the year and Jane has a $500 deductible. And what that means is Jane has to pay the first $500 of her medical care herself before the insurance company begins to pay. And so it's a $300 bill. And so Jane, the insurance company in this situation, does not pay the $300 bill. So then the provider then sends a bill to Jane saying, you owe us $300 because you came and see the doctor on this such and such day, right? And you have a deductible of $500, and so you haven't met that yet. So Jane writes a check for $300 and sends that to the doctor. Now, Jane still has $200 left on her deductible to pay before Blue Cross Blue Shield pays, right? And so 3 months go by, and Jane goes back to the doctor, and the doctor writes up another $300 bill. And so this time, the insurance company says, okay, we will pay, of the bill, $200 qualifies for us to reimburse the doctor, right? Jane has to pay $100, right, to satisfy her deductible, right? And now you might think, okay, well now Blue Cross Blue Shield is going to pay the entire $200, but they're not, because there's oftentimes a copay associated with this, which means the insurance company will say, we will pay 80% of the bill after the deductible is met. And so you've got a $200 bill, and Blue Cross Blue Shield says, okay, we're going to pay 80% of that $200 bill. And so that is what? $160. And so Blue Cross Blue Shield sends $160 to the doctor. And that means the doctor comes back to Jane and says, okay, you owe $100 to meet your deductible, and then $40 to meet your copay. right? So, all right. Before the Affordable Care Act, there was something called fixed indemnity, which meant that, let's say Jane had some sort of catastrophic thing happen. Let's say she develops cancer, and it's a $2 million bill that she has from the various doctors and specialists that she sees. Blue Shield may say, okay, we have a fixed indemnity of $1.5 million, which means after that, we're not paying anything because you've maxed us out. We've spent all we're going to spend on you. So then Jane is now responsible for the last $500,000, of which Jane's not going to be able to pay, so she is likely going to have to declare bankruptcy from this, right? Okay, let's say in this situation that Jane wants to get braces, right? And so she goes to the orthodontist and says, hey, I'd like to get braces. And the orthodontist says, oh, okay, do you have insurance? And she says, yes. And so then they try to bill Blue Cross Blue Shield, but they say, no, braces, which are not usually medically necessary, they're considered cosmetic, that is excluded. We don't pay for braces, right? So exclusions are an important part. Sometimes this is braces, sometimes this is like massage therapy, or just various mental health. Could be drugs, drug treatment. It could be just various things that are excluded from the policy. So, all right. The cost of health insurance increases with age and as technology increases, right? So we may create a new pill that's able to help people with a certain type of, say, rectal cancer, but that pill may be $2,000 a month. So that's going to increase the cost of health insurance. For the individual, their age, they become a higher risk of developing more expensive disorders and illnesses, and so the insurance company is going to pass that on, because in a sense, what you are doing when you purchase insurance, pretty much of any kind, car insurance, health insurance, life insurance, is saying, I am betting against my own health, right? So if you buy health insurance, you're saying, I'm betting that I'm going to get sick and need care. The insurance company takes the other side of that bet and says, okay, we are betting that you're not going to, right? So you end up spending $5,000 a year, but you only end up using $4,000 worth of health care. Well, the insurance company profits that $1,000 because they took the other side of that bet, right? Life insurance is the same way, especially if you buy term life insurance, which just means over the next 20 years, this is what we did, and we have kids, and we're responsible for their care, and so we're going to say we're betting. Well, I hate doing it, saying it this way, but it's like we're betting that we're going to die, and the insurance company says we're betting you're not going to die. So so we're paying them $50 a month. And if we were to die, then they would send a check to whoever it is that's going to care for our children, and then they're saying, well, we don't think you're going to die, so we're only going to charge you a little bit amount because the odds are in their favor, right? Not in my favor. So, all right. But there are also some companies that are self-funded, and that means the employer pays for the health care costs themselves. So, all right, well, let's talk a little bit more about health insurance, since we have some of the terms under our belt, right? So in the I think it was the 80s, the cost of health care started going up significantly because traditionally the employer would pay for the health care of their employees, and it started to go up a lot, and so they began looking for alternative ways of paying for it. And managed care was the thing that they came up with. Now, managed care, if you look at the words, you're managing the care of your customers, right? And you're trying to reduce the cost of providing health care for those people, right? Most people in the United States are in some sort of managed care system. if you receive health insurance through your employer, 90% of those are in some sort of managed care, right? The goal is to increase the efficiency and the coordination, not do unnecessary services, increase the access to preventable care. Preventable care is much cheaper than allowing a disorder to pop up and having to treat that, and then increase the quality of that care. And so through managed care come things like in-network providers. So we go back to our example with Jane. Her doctor may be in-network. That means that the healthcare insurance is going to pay for 80% of the bill after she meets her deductible. But if the doctor is not in-network, then maybe the health care insurance will say, well, we're only going to pay 60% of the bill, right? Encouraging Jane to leave that doctor that's out of network and go with one that is in network. And what makes a doctor in network is that the healthcare insurance company has created an agreement with them for in exchange for the healthcare insurance is going to steer people toward their practice, and as a reward for that, the provider is going to decrease the cost. It limits the amount of choices. It gatekeeps, and so if it's a specialist, you have to receive a referral in order to go there, and then it obviously shares risk. That's the idea of insurance, is that you're sharing the risk with a bunch of other people. It's the same thing with fire insurance. The odds are you are not going to burn down your house, but just in case you would, you're better off contributing a little money each month so that if one day it was your house, there's all this kind of money that's sitting in the insurance company's bank account that then gets to come to you. So, all right, there's a couple of types of managed care. PPO, which stands for Preferred Provider, option. For this, the fee that the insurance company is going to pay to the provider has been fixed. Right? And this is actually more common than HMO, or Health Maintenance Organization. And in this situation, payments are made to providers each month whether or not the care has been provided, with the idea that the physicians are going to take responsibility for the patients that are in their care. And so if you work at an organization that has an HMO, that's their health insurance policy, then you would be given a list of providers that are on as a part of the plan. And then you would go to one of those, and then the physician sends you and coordinates the care that the people need. And so it's almost like a membership, like a gym membership to this one. So, all right, we're almost done. Nationalized health insurance is not what we have in the United States, unless you consider Obamacare or the Affordable Care Act, nationalized health care. But every other rich country in the world has nationalized health care. And what that means is everybody is provided with health insurance by nature of being a citizen of that country. Right? There's two types of healthcare, nationalized healthcare. There's one, like what they do in Great Britain and Spain and Italy and Greece, and that is where doctors and healthcare providers in general are government employees. And so the government basically runs all of the healthcare in that country, or in those countries. And then the other one is where the government merely provides the health insurance, and then kind of like what Blue Cross Blue Shield does, and then people, to some extent anyway, choose the provider that they want to go to. And so the government becomes the health insurance provider, kind of like with Medicaid and Medicare today. And so, in fact, that's kind of one of the things that politicians will run on, and they'll say, we want Medicaid for all. So the same health insurance that people who have Medicaid receive, that would just be extended to every American. So a lot of stuff here. But that's why our book talks about it as pretty scattered. Our healthcare system is kind of a patchwork and a little disorganized. So, but that is chapter 11.